are presenting a very important and interesting topic. As we do conduct every second Tuesday of every month, we are conducting a few programs in the Public Health Subcommittee. I am Chairman Dr. Padma Prakash. So it is very important, like in our daily practice, being medical professionals. So we come across a lot of cases where we would have missed by taking the consent, or even we document it. So we would have left the paper somewhere, or it is not it's there in the system also. So in such cases, we do come across the medical negligence cases. So the data says that almost 5.2 millions of cases have been documented as a medical legal negligence cases. It has almost increased from 2% to 32% of the latest. So we thought this is very interesting topic to be discussed. Now, may I request Dr. Karunakara sir to do IMA prayer? Sir, are you present, Dr. Karunakara sir? I think Dr. Rajendra Prasad sir, please do IMA prayer, sir.
Sure, madam. Thank you, madam. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. Thank you.
Thank you so much, Dr. Rajendra Prasad sir. Now I request our Honorable President of IMA KSB, Dr. Srinivas sir, to do the presidential address.
Yes. So, good evening, everyone. As usual, Dr. Padma Prakash is conducting this type of talk, especially the second Tuesday. So, even though she primary speaker not there, she doesn't want to lose this today's topic. I have to very much thankful to her, and I should appreciate and acknowledge her effort that she wants to continue with that. Same way, I also do so many times whenever, since I am especially in hospital where I am working as a professor, head of the department. Little bit to one student, if some was sick, she couldn't present also, I'll arrange somebody and I'll make it. So without lapses, some classes should be there that day. Same anyhow, she has done, she is doing the same thing. And anyhow, today is the most important, the medical negligence, especially. And so many times, so many hidden problems will be there. And without our knowledge, we will be doing so many mistakes. So these are the things happen. But as he told, documentation is very, very important. Whatever documentation you need to clear cut, even in OPD wise also we have to do it. See what we should do, as is the name means everything we do so. And date and time of examination we have to do. Always time, which time we are examining that time. Suppose now 9 o'clock. Just now I wrote on 2 patients. Just now 8:45 time I wrote. Like that we have to write down. After that we have to write no fevers is 1 day, pain abdomen is 2 hours, like that. So to match, definitely it takes care of that, especially matching. This is the most important medical negligence. Just now evening I got a call from hospital, especially Dr. Sadia. He called me that some problem has happened there, and yesterday baby died because the ICU. And today DC called, DC, DHO, everyone there, and he told that he spoke very badly, DC, and now all over the hospital, now we are planning to go on strike, they told. So ultimately, one day time they gave, he is a central working committee, Dr. Sali. He is central working, he has taken 1 day, so that tomorrow again I will call for the meeting, sir. Today everyone is emotional. Tomorrow we little time, we'll call them. Suddenly, if we go on strike, what to do our patients? I'm the neurosurgeon. I have to do some surgery now. I already posted. One more, my other close, this only joint surgery is posted. We'll give 1 day time. Tomorrow we'll call for the meeting and we'll decide it. All these problems we are all facing. So, but we should have exactly what is the legal point, what is there exactly, what is the issue, all these aspects. Even this Thursday also, our urban DC also, he called for the meeting to discuss about KPME and PCPNT role and all these things. I am going to attend also on Thursday too, exactly 1 o'clock. So all this happen. If any chances is there, please keep attending all the higher officials whenever they call the meeting and any if you have a little bit chance also, we can put all this on behalf of our doctors association. You can tell them also. Anyhow, without much taking much time, so I have to thank and I have to welcome all Suresh Kagalkar is there, Veena is there, Dr. Satish is there, Dr. Jay Prasad is there, and Ravindra Kaje is there. Our secretary, Dr. Karnakar, I think he came, he is there, I think. Dr. E just now he entered. So I have to welcome him also, Dr. Karnakar. And Rajendra Prasad, I have to thank him. And he has taken through this one today. He is going to discuss completely this topic. So thank you. And I hand over this one program to Dr. Padma Prakash. So let her continue with this. Thank you, madam. Go ahead, madam.
Thank you so much, sir, for your kind words. And you enlightened us about what is the importance of this taking the consent. So the patients will consider as a medical negligence, even legally also. So we have to be very careful, and you explained what happened today. And I don't want to take much time, as I said. Because I wanted to do one more thing. Dr. Karnakar, this morning he called, sir.
Idini sir,
Welcome, Dr. Karnakar, sir.
ಕೇಳಿಸ್ಕೊತಾ ಇದ್ದೀನಿ. Thank you. I'm here only.
Thank you, sir.
Okay.
Thank
So
you.
what happened, Dr. Kamba, sir, mother is not well, sir. So she
Yeah.
is admitted that in ICU. So morning he had informed me. So because we had sent the widely in the WhatsApp group, so we didn't want to like cancel the program. Now I think next month he'll be updating us more regarding this. But today, Dr. Rajendra Prasad, he'll be updating us what is the importance of this taking the consent. I think I'll hand over the mic to Dr. Rajendra Prasad. Sir, please go ahead. Thank you so
Yes,
much.
I'll be speaking for only few minutes, madam. Later we can have discussion. I will share the screen. Are you able to see the screen, madam?
Yeah.
Yes, sir.
Oh, yes. Doctoring is the riskiest profession of all because according to Business Standard magazine, over 5.2 million medical malpractice cases are filed in India annually, and it is increasing at a very high rate, that is litigation surged by 400%. Why it is increasing? There are many reasons. Main reason is colleagues lose comments, rivalry, jousting. This is the first and foremost. What we have to learn as a doctor is we should not comment on the other doctor's treatment. Even if you say a single word against the other doctor, that may lead to litigation and lot of problem to our fellow physician. You see, the success rate has of the claim has also increased. Here, success rate is from 2% to 34%, because lot many judges and courts are thinking anyway the person has lost something, we shall compensate him. Definitely not, because our judicial system is not mature enough to understand the difference between the medical negligence and the complication and the medical errors. And 93 acts are applicable to the doctors, and the new act is that is Consumer Protection Act. Till recently, we were governed by only one act, that is Medical Council Act. Definition of the medical negligence was based on Bolam test, that is Bolam's principle, what we say, whether the reasonable care was given to by the doctor with the average skill and knowledge. But now things have changed. That is, now the Bolito principle and the Montgomery principle are applied, where the judges will see beyond the expert opinion. And so also, it is my body and it is, I have got right. You see, the patient has got all the right to know everything about the disease and every complication of the disease, and he has got right to choose which treatment he wants to take and how long he wants to be treated. And that is what the new principles are. And the Consumer Protection Act, healthcare is the fundamental right of every citizen. Because of poor spending by the government,
I think, madam, sir is internet fluctuation. Sir left, I think.
ಏನಾಯ್ತು?
Yes, sir, the net is slow back, sir. Yes.
ನೆಟ್ಟಿನ ಪ್ರಾಬ್ಲಮ್.
He's rejoining.
Good.
Sir. Rajendra Prasad, sir, you can unmute and speak.
Hello.
yes, sir. Yes, sir.
Yeah.
You are able to see my screen, sir?
Yes, yes.
Yes,
Yeah.
yes.
You can make big screen, sir.
Yes, I will make it.
Yes, sir. Go ahead, sir.
Yes, sir. And because of the poor governance and high corruption, government is able to cater to only 30% of the population. Other 70% depend on private health sector. Instead of facilitating the private hospitals who are taking care of the such a majority of the patients, government is harassing doctors every day by bringing new laws. If one adverse event happens in the clinic or the hospital, patient can give police complaint and ask for jail punishment, give complaint in medical council and ask for cancellation of his medical degree, give complaint in District Consumer Commission and ask for compensation, and give complaint under Clinical Establishment Act, that is KPME, and ask for closure of the clinic and hospital, give complaint in the Human Rights Commission, and all this happens simultaneously. The worst part is the vicarious liability. Whatever is done by agents, subordinates, contractors, employees, doctor is responsible. Generator is not working, doctor is responsible. Whether there is a fire accident, a doctor will go to jail. Patient can complain in the consumer commission by sending email. That is no fees paid or even very negligible paid, a negligible amount. Even if he is suing 1 crore, what the patient side has to pay is only 5,000 rupees. And District Consumer Commission tries deficiency in service of the doctor and excess charges for service, unfair trade practice. As you see, these parameters are undefined and ambiguous, which means doctor is fully under the mercy of the commission. If the doctor is not happy with the order, the commission, that is the commission, he has to deposit 50% of the compensation and file appeal, which will go for many years. Patient may file false or frivolous complaint just to harass the doctor, and there is no penalty for filing false and frivolous complaints. Total patients' rights are there in not in all countries. In USA it is there, and they are now facing some problem. And people in countries like Denmark and New Zealand, patient cannot sue the doctor. If patient suffers any loss due to medical complication, government pays the compensation, and this government know doctor cannot do his best if his hands are shaking. How doctor can save himself from CPA? That is perfect counseling, perfect consent, and perfect documentation. Everything has to be perfect. Taking procedure specific informed consent, handwritten, better handwritten by the patient or the receptionist and signed by patient, attendant, receptionist, doctor, and the ward nurse is better. Informed consent shall include procedure, alternates, and risk of each procedure, complications of every procedure, outcome, and duration of the treatment, and better expenditure also. Is it practicable? Foxy has come out with the consent of 16 pages, all printed or handwritten. Consent on pre-printed form to fill up the blanks is unfair trade practice, and whatever it is, law is as we have to just follow it. And do not treat the patients from other districts, because if that district is not having online hearing, the doctor will have to go to that district. And critically ill patients better stabilize and refer to equipped hospitals. And do not treat super rich patients and very high category patients. That is politicians, advocates, and police officers. Better to be away from them, because they can easily close our clinics, because the rules are very ambiguous. And in contrast to the popular belief, government doctors, ESI doctors, and resident doctors also need indemnity insurance, because medical practice is based on probabilities and full of uncertainties. Since compensation is likely to go up, if you don't have indemnity insurance, do not touch the stet or knife, you may become bankrupt. Take indemnity insurance first. And take-home message in brief is, listen to the patient with respect and involve the patient in the decision, and apply knowledge and skill has to be up to date. Thank you. I am a professional protection scheme. Indemnity insurance is the cheap and the best thing. I request everybody to go with it. And I have got some more slides. I'll just finish in another 5 minutes. You are able to see, sir?
Yes, sir. Yes, sir.
Yes, sir. Legal aspects in medical practice. So these slides are from Dr. Rahul Katta of Jaipur. Only some of the points I'll be taking from here. As you see, when the doctor is in problem, the law will not come to his help, media, public, politicians, and the police. Nobody will come to his help. And laws are not very clear for the doctors. There are so many rules, Indian Medical Association ethics, and building radiation protection, blood bank rules, Drugs and Cosmetics Act, Birth and Death Act, and PCPNDT Act, MTP Act, and law of torts. And the fear that is palpable. The recent survey by IMA report show that 80% of the doctors in India are stressed out in their profession, which is worrisome. And there is no limitation for the liability. IMA, Karnataka is giving 1 crore, but some of the courts have awarded 5 crores for some of the things. You see, the Supreme Court orders Calcutta Hospital to pay 5.9 crores because of the death from cesarean section. If it happens to I and you, where we should go? And medical errors and medical malpractice, entirely different thing, but for the court, everything it is same, because either they don't listen to the experts. So negligence is taken by 4 Ds. That is, there has to be duty towards the patient. There is a deficiency in duty and directly resulting in injury, and damage has to be there, either physical, mental, or financial losses. And theory of negligence is by commission, that is doing unnecessary things or unnecessary, giving unnecessary or wrong drugs, or by omission, failure to attend the patient, failure to investigate adequately, failure to take a consent, or failure to hospitalize, or failure to attend, refer in time. What is not negligence is the difference of opinion, wrong diagnosis, accidents, unexpected results. Who will sue that I have told. And in emergency, the courts are very particular. In emergency, it is the doctor's responsibility to see that correct treatment is given. So what I suggest is, if there is an emergency, the doctor himself has to take the patient to the nearest hospital where the care is available. It is always better doctor takes, because if the patient dies in the ambulance, the judges look it in a different way. And medical record, when it is there, it has to be very much perfect. When it is not perfect, as you see here, medical record in themselves may be very source of lawsuit. What you have done is different, but what you have written, that is more important. And don't alter the record. That is single line through the entry, initial, and date and time of the entry. And when there is a error, don't write error. And medical certificate and all, it is not. And consent has to be taken. So doctor and the patient both should sign the consent at once. And separate consent for anesthesia is required. And emerging trend is for blood transfusion, separate consent is required. For sterilization, both husband and wife consent is required. And for MTP, it is a very tricky, that a lot of counseling is required. And then only MTP has to be done, because she should not tell that it was done in a hurry. And better take the consent of husband also. Consent for publication of the photos or the data of the patient, and it is very much necessary. And refusal, when the patient refuses anything, say a CT scan, patient has refused, that has to be written very clearly. And copies of all the records the hospital or the doctor should take. And do not forget to renew medical council registration, and employ qualified assistants. And communication. If the communication is good, lot of medical malpractice litigations can be avoided. And appeal to the doctors. When you are the second doctor, you should never comment on the first doctor's way of treatment or his treatment line. And assigned to sinner. We are assigned when the patient comes, and when the bill is given or something goes wrong, we are a sinner. And as you see here, 53 doctors attacked in 2 years and 0 convictions. And somehow even judges are very lenient to the patient side. As you see here, her name is Archana Sharma. Even now, she has not got the justice. I was told that police officer who booked under her under murder charges, he is on bail. He went to jail, but he is still on bail. She hasn't got the justice. Of course, it is very much delayed here. Doctors assault and deceased patients ready to attack the resident doctor, and baby dies. A family beat up the doctor. This we see every day, and the fear in the doctors is visible, and there are many ways how we can prevent it. That okay, that is by itself it is a very big subject, and this is very important. You have heard them, hear to the patient very carefully. You have understood them, understand the patient's pain carefully, and you have felt their worry. You feel what really patient wants. We can do only what patient want. And in conclusion, increase of the materialism, increase of the cost, and a negative image by the medical profession. There are 3 full-time films which show that greedy doctor admits a dead body in the ICU and the bills, which is just impossible. And something violence, it is we see everywhere, and it is a different subject, and we should have a completely full-length CMA on that. I will stop the sharing now. Thank you, sir. Thank you very much. Madam, we can go for discussion.
Yes, sir. Thank you.
Madam, kelista idea?
Yeah. Thank you so much, Dr. Rajendra Prasad, sir, for your elaborate talk. We got few questions on the screen. What about consent in medical cases where no procedure involved?
No,
There is no procedure. What is the role of consent in
no,
medical
no.
cases?
Madam, there is implied consent. The very fact the patient comes, walks into the patient's consultation chamber, that is a implied consent, that it is limited to that. Even if you are suturing a lacerated wound, consent is a must, because the patient may say that you are assaulting. It amounts to assault if you are not taking consent and if you are operating on his body. That is the way law is interpreted today. So anything other than that, just consultation, the patient walks in, that is an implied consent, that is enough.
Whether consent is required to insert IV cannula, whether consent is required to give injections.
Maybe that is the implied thing, madam, for injection. If the injection is going to cause any problem, then definitely written consent is required, because the patient has to understand what injection you are giving, why you are giving, and what problems it can create, whether it can it create any problem. If he is accepting the risk, then only we should touch the patient, otherwise not.
So day in and day out practice, sir. Example, when we are giving vaccinations in pediatric cases, I don't think we are taking any consent. Just we inform them like this. These are the vaccines we are giving to the child. But in my day in and day out practice in outpatient departments, we are not taking any written consent for the vaccinations, of course. What about Dr. Srinivas, sir? What do you say, sir?
Madam,
Because
they will come for the vaccination only.
ಹೌದು ಅದು ಇಂಜೆಕ್ಷನ್ ಅಲ್ವಾ ಸರ್?
ವ್ಯಾಕ್ಸಿನೇಷನ್ ಬಂದು ನಾವು ಹೇಳ್ತೀವಲ್ಲ ಇದೇ ವ್ಯಾಕ್ಸಿನ್, ಸಪೋಸ್ ಈಗ ಡಿಪಿಟಿ ಕೊಟ್ರೆ ಫೀವರ್ ಬರ್ತದೆ, ಎವ್ರಿಥಿಂಗ್ ವಿ ಆರ್ ಎಕ್ಸ್ಪ್ಲೇನಿಂಗ್ ದೆಮ್.
ಹೌದು, ಬಟ್ ನಾವು ಕನ್ಸೆಂಟ್ ಅಂತ ಏನು ತಗೊಳ್ಳಲ್ಲ ಅಲ್ವಾ ಸರ್?
ಅಲ್ಲ, ಕನ್ಸೆಂಟ್ ತಗೊಂಡು ಸಿಗ್ನೇಚರ್ ಇಲ್ಲ, ವ್ಯಾಕ್ಸಿನ್ ಕಾರ್ಡ್ ಎತ್ಕೊಂಡ್ ಬಂದು ಕನ್ಸೆಂಟ್ ಅಂದ್ರೆ ವಾಟ್ ಎವರ್ ದಿ ಓರಲ್ ಕನ್ಸೆಂಟ್ ವಿ ಆರ್ ಟೇಕಿಂಗ್, ಬಟ್ ದೇ ವಿಲ್ ಕಮ್ ಫಾರ್ ದಟ್ ವಿ ಹ್ಯಾವ್ ಟು ಎಕ್ಸ್ಪ್ಲೇನ್ ದೆಮ್ ಕಂಪ್ಲೀಟ್ಲಿ. ಅದಕ್ಕೆ ಅಂತ ನಾವು ತಗೊಂಡು ಸಿಗ್ನೇಚರ್ ಏನು ತಗೊಂತಾ ಇಲ್ಲ, ಇಟ್ ಇಸ್ ನಾಟ್ ರಿಕ್ವೈರ್ಡ್ ಅದಕ್ಕೆ ಅಂತ, ಬಟ್ ಇಟ್ ಅವರ್ ಡ್ಯೂಟಿ ಟು ಎಕ್ಸ್ಪ್ಲೇನ್ ಎವ್ರಿಥಿಂಗ್,
ಅದಕ್ಕೆ ಈಗ
ಇನ್ಕ್ಲೂಡಿಂಗ್ ಕಾಸ್ಟ್, ಅಡ್ವರ್ಸ್ ಇಫೆಕ್ಟ್ಸ್ ಎಲ್ಲ ನಾವು ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡಬೇಕು.
ಇನ್ಕ್ಲೂಡಿಂಗ್ ದ
Vaccination.
ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್. ಯಾಕಂದ್ರೆ DPT ಎಲ್ಲ ತಗೊಂಡಾಗ they get fever ಅಲ್ವಾ
ಹೌದು,
ಸರ್? ವ್ಯಾಕ್ಸಿನ್
ಹೌದು.
ಮಾಡಿದಾಗ they
ಅದನ್ನೆಲ್ಲ
get
ಹೇಳ್ಬೇಕು
post
ನಾವು.
vaccination fever ಎಲ್ಲ ಬರುತ್ತೆ. ಅದೆಲ್ಲ ಹೇಳ್ತೀವಿ
ಅದೆಲ್ಲ
ಬಟ್ ವಿ
ಹೇಳ್ತೀವಿ.
ಡೋಂಟ್ ಟೇಕ್ ಎನಿ ರಿಟರ್ನ್ ಕನ್ಸೆಂಟ್ ಅಂತ. ಅದಕ್ಕೆ ಅಲ್ಲಿ
ಇಲ್ಲ,
ಕ್ವಶನ್ ಇರೋದು
ಅದಿನ್ನೂ
ವೆದರ್ ಎನಿ
ಬಂದಿಲ್ಲ.
ಕನ್ಸೆಂಟ್ ಇಸ್ ರಿಕ್ವೈರ್ಡ್ ಟು ಇನ್ಸರ್ಟ್ IV ಕ್ಯಾನುಲಾ ಆರ್ ಇಂಜೆಕ್ಷನ್ಸ್ ಅಂತ.
Even IV cannula we are not taking. Even the consent we are not taking.
Correct.
Sometimes ಏನಾಗಿದೆ ಅಂದ್ರೆ ಈಗ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಬ್ಲಡ್ ಸ್ಯಾಂಪಲ್ ಕಳಿಸ್ಬೇಕಾದ್ರೆ so many times IV cannula ಅನ್ನೇ ಡ್ರಾ ಮಾಡ್ತಾರೆ ಈಗ. And just to maintain that, ಅವಾಗ ಯಾರು ಸಿಗ್ನೇಚರ್ ಹಾಕಿ ಇಟ್ ಇಸ್ ಅಂಡರ್ಸ್ಟುಡ್ ದಟ್ ಈಗ ಸಪೋಸ್ ಪೇಷಂಟ್ ಅಡ್ಮಿಟ್ ಆದ್ರೆ ಅವಾಗ ಕನ್ಸೆಂಟ್ ತಗೊಂಡಿರ್ತೀವಲ್ಲ.
Except HIV testing and for no other test, consent is required. HIV test counseling and consent is required.
Anybody in the audience have any questions to be clarified, or any faced any issues, or you want to update us anything? It's open. The forum is open for all of us.
ರವೀಂದ್ರ ಸಾಹೇಬ್ರು ಹೇಳಿ, ಪುತ್ತೂರಲ್ಲಿ ಏನಾನ ಆಗಿತ್ತ ಅಂತ ಹೇಳಿ.
Senior most ಎಲ್ಲ ಸ್ವಲ್ಪ please come out with
ರವೀಂದ್ರ
your
ಅವರು
any experiences so that everybody will be highlighted. ಅನುರಾಧ ಮೇಡಮ್ ಇದ್ದಾರೆ, ಗಿರೀಶ್, ಡಾಕ್ಟರ್ ವೀಣಾ, ಡಾಕ್ಟರ್ ಪ್ರಕಾಶ್, ಪ್ರಭಾ. It's an open forum. It's an open forum for discussions. Any questions or any of your experiences of the latest news, you can have an open discussion.
There is a chat, this thing, madam, whether thumb impression is required or a signature of the patient is enough. And then there is this is somewhat a tricky situation. Some of the hospitals take video consent. It is a good idea, but in the video consent, doctor and patient should be there, and patient should listen to every point in the consent paper. You see, consent paper of the delivery itself is 16 pages, means if it is a surgery, definitely it will be a bigger, it will become a big booklet. And everything you have to tell, and patient has to listen and carefully understand. When you are doing a video consent or video counseling, if the patient is seeing a roof or something like that, then it is again, it is of no use, because that itself will become problem when it goes to the court. You see, you have told that patient has not understood. That is why written consent also should be there, and video consent is also very good, and patient should understand every point, every risk patient should understand. If, for example, in MTP and all, perforation of the uterus, even if it is 0.1%, patient should understand that there is a risk. And people say, if we tell all the risk, patient will not come, we will not understand.
ಈಗ ICU ನಲ್ಲಿ ರಾಜೇಂದ್ರ ಪ್ರಸಾದ್ ಅವರು.
Yes, sir.
ಯಾಕಂದ್ರೆ ನಾನೇ ಕಿಮ್ಸ್ ಅಲ್ಲಿ ಇದ್ದಾಗ, HOD ಆಗಿದ್ದಾಗ, ಐ ಫೇಸ್ ಲಾಟ್ ಆಫ್ ಪ್ರಾಬ್ಲಮ್ ಇನ್ ICUs. ICU ನಲ್ಲಿ ಇವನ್ ಪೊಲೀಸರು ಗಲಾಟೆ ಆಗಿ ಬಂದ ತಕ್ಷಣ ರೆಕಾರ್ಡ್ ಮಾಡಿದೀರಾ ಅಂತ ದೇ ವಿಲ್ ಆಸ್ಕ್. ಎಸ್ಪೆಷಲಿ ICU ನಲ್ಲಿ ಆಲ್ವೇಸ್ ಬೆಟರ್ ಯು ಶುಡ್ ರೆಕಾರ್ಡ್. ಯಾಕಂದ್ರೆ ಎಷ್ಟೋ ಸರಿ ಅಟೆಂಡರ್ಸ್ ಏನ್ ಮಾಡ್ತಾರೆ, ಇನ್ನೇನು ಪೇ ಮಾಡ್ಬೇಕು ಅಂತ ಟೈಮಲ್ಲಿ ಇಲ್ಲ ಅದೇಳಿಲ್ಲ ಇದೇಳಿಲ್ಲ ಅಂತ ಶುರು ಮಾಡ್ತಾರೆ. ದೀಸ್ ಆರ್ ದ ಪ್ರಾಬ್ಲಮ್ಸ್ ವಿತ್ ಎಸ್ಪೆಷಲಿ ICU ನಲ್ಲಿ ರೆಕಾರ್ಡ್ ಮಾಡ್ಬಿಟ್ರೆ ಡೈರೆಕ್ಟ್ಲಿ ನಮ್ಮನ್ನೇ ಕೇಳಿದ್ರು ಪೊಲೀಸ್ನವ್ರು, ರೆಕಾರ್ಡ್ ಮಾಡಿದ್ರಿ ಅಂತ. ರೆಕಾರ್ಡ್ ಮಾಡಿದೀವಿ ಅಂತ ತೋರಿಸಿದ್ದಕ್ಕೆ ವಿತೌಟ್ ಎನಿ ಪ್ರಾಬ್ಲಮ್ ದೇ ಸಪೋರ್ಟೆಡ್ ಅಸ್. ದಿಸ್ ಇಸ್ ದ ಎಸ್ಪೆಷಲಿ ICU ನಲ್ಲಿ ಪೇಷಂಟ್ ಡೆತ್ ಆಗೋವಾಗ ಬೆಟರ್ ವಿಡಿಯೋ ರೆಕಾರ್ಡ್ ಮಾಡೋದು ಬೆಸ್ಟ್. ವಿ ಮೇಡ್ ಇಟ್ ಆಸ್ ಎ ರೊಟೀನ್ ಅವಾಗ. ಬಟ್ ಈಗ ಸರ್ಜನ್ಸ್ ಸ್ವಲ್ಪ ಇನ್ಫಾರ್ಮೆಂಟ್ ಕನ್ಸೆಂಟ್ ಮಾಡುವಾಗ ಎಷ್ಟೋ ಸರಿ ಗುಡ್ ಕ್ಲಿನಿಕಲ್ ಪ್ರಾಕ್ಟೀಸ್ ಇರೋದ್ರಲ್ಲಿ ಇವನ್ ಎಷ್ಟೋ ಸರಿ ಅದನ್ನ ರೆಕಾರ್ಡ್ ಮಾಡ್ತಾರೆ. ಇವನ್ ಡೆಸರ್ಟೇಷನ್ ಮಾಡುವಾಗ ಅಷ್ಟೇ, ಇದೆಲ್ಲ ಅಷ್ಟೇ. ಈಗ ಸಪೋಸ್ ಆನ್ ದೇರ್ ಓನ್ ಲ್ಯಾಂಗ್ವೇಜ್ ಯು ಹ್ಯಾವ್ ಟು ಎಕ್ಸ್ಪ್ಲೈನ್. ಸಪೋಸ್ ಕನ್ನಡನ, ತೆಲುಗು, ಮಲಯಾಳಂ, ಆನ್ ದೇರ್ ಓನ್ ಲ್ಯಾಂಗ್ವೇಜ್ ನಾವು ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡ್ಬೇಕಾಗ್ತದೆ. ಸಪೋಸ್ ಏನಂದ್ರೆ ಇನ್ಫಾರ್ಮೆಂಟ್ ಗೆ ಏನಾದ್ರೆ ಇಂಗ್ಲಿಷ್ ಬರಲ್ಲ ಅಂದ್ರೆ ವಿ ಹ್ಯಾವ್ ಟು ಕಾಲ್ ಸಮ್ ಅದರ್ ಒಂಥರ ನ್ಯೂಟ್ರಲ್ ಪರ್ಸನ್ ಕರೆದು, ದೇ ಶುಡ್ ನಾಟ್ ಬಿ ಇನ್ ಅವರ್ ಟೀಮ್ ಅಲ್ಲಿ ಇರ್ಬೇಕು. ನ್ಯೂಟ್ರಲ್ ಪರ್ಸನ್ ಕರೆದು ಅವರು ಮುಂದೆ ರೆಕಾರ್ಡ್ ಮಾಡಿಸ್ಬಿಟ್ಟು ಲ್ಯಾಂಗ್ವೇಜ್ ಇದ್ ಮಾಡ್ಬಿಟ್ಟು ಅವಾಗ ಅವಕ್ಕೆ ಸಿಗ್ನೇಚರ್ ಇವ್ರ ಸಿಗ್ನೇಚರ್ ಎರಡು ತಗೋಬೇಕು. ಈ ತರ ಸುಮ್ಮನೆ ಆಸ್ಪೆಕ್ಟ್ಸ್ ಇದೆ. ಎಸ್ಪೆಷಲಿ ಕನ್ಸೆಂಟ್ ಇದೆಲ್ಲ ನಾನು ಲಾಟ್ ಆಫ್ ಥಿಂಗ್ಸ್ ಅದರೆಲ್ಲ ನಮ್ಮ ಲಿಟ್ರೇಚರ್ ಅಲ್ಲೇ ಇದೆ. ಗುಡ್ ಕ್ಲಿನಿಕಲ್ ಪ್ರಾಕ್ಟೀಸ್ ಅಲ್ಲಿ ಯಾವ ತರ ವಿ ಹ್ಯಾವ್ ಟು ಟೇಕ್ all these to safeguard ourselves. All these things we have to do it. ಅಷ್ಟೇ. All these things.
Yes, sir.
ಸರ್ ಇನ್ನೊಂದು ನಾನು ಡಾಕ್ಟರ್ ರಾಜೇಂದ್ರ ಪ್ರಸಾದ್ ಅವ್ರ ಸ್ಲೈಡ್ ಅಲ್ಲಿ ನೋಡ್ತಿದ್ದೆ ಸರ್, ಡೋಂಟ್ ಟ್ರೀಟ್ ಔಟ್ಸೈಡ್ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಪೇಷಂಟ್ಸ್ ಅಂತೀರಾ. ಹೌ ಇಟ್ ಇಸ್ ಪಾಸಿಬಲ್ ಸರ್? ಯಾಕಂದ್ರೆ ಕೇಸ್ ಆದ್ರೆ ನೀವು ಹೊರಗಡೆ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಹೋಗ್ಬೇಕು ಅಂತ.
ದಟ್ ಇಸ್ ಒಂದು ಟ್ರಿಕಿ ಸಿಚುವೇಶನ್ ಮೇಡಮ್. ನಾನು ಹೇಳ್ತೀನಿ ಹೇಗೆ ಅಂತ. ಪೇಷಂಟ್ ಕ್ಯಾನ್ ಸೂ either the place of treatment or the place of residence ಅಂತ ಅಂದ್ಬಿಟ್ಟು. And if the patient from Ballari takes treatment in Bangalore, if he can sue either in Ballari or in Bangalore. In the Ballari, if the district commission has got online hearing, then okay, from here you can defend. Ilda idre enagutte, you have to engage advocate in Ballari and the doctor has to go to Ballari. What about even Biharis are here in my place? If I give treatment and something goes wrong, they can sue me there also.
ನೀವು ಹೇಳಿದ್ರೆ ಹೆದರಿಕೆ ಆಗ್ತದೆ ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡಕ್. ಮತ್ತೆ ನಮ್ಗೆ ಇಲ್ಲಿ ಎಷ್ಟೋ ಜನ ಬಳ್ಳಾರಿಯವರು ಬರ್ತಾರೆ ಈಗ.
ಹೌದು.
ಹಾಗಾದ್ರೆ ಬಳ್ಳಾರಿ ಬಂದ್ಬಿಟ್ರೆ ಹೆಂಗಾಗ್ತದೆ? ಬಿಹಾರದವರು ಬರ್ತಾರೆ, ನಮ್ಮ ಮನೆ ಹತ್ರ ಬಿಹಾರದವರಿದ್ದಾರೆ.
ಲಕ್ಕಿಲಿ ಈಗ CPA ಹೋಗುವಾಗ ಕಾಣ್ತಾ ಇದೆ, ಹೋಗಬಹುದು. ಯಾಕೆಂದ್ರೆ ಈಗಿನ ಟ್ರೆಂಡ್ ನೋಡಿದ್ರೆ ಇವತ್ತಿನ ನ್ಯೂಸ್ ಪ್ರಕಾರ ಲಾಯರ್ಸ್ ನ ತೆಗೆದಿದ್ದಾರೆ. ಮತ್ತೆ ಎಲ್ಲರೂ ಹೇಳ್ತಿದ್ದಾರೆ ಆನ್ ದ ಸೇಮ್ ಗ್ರೌಂಡ್ ಡಾಕ್ಟರ್ಸ್ ಆಲ್ಸೋ ವಿಲ್ ಬಿ ಔಟ್ ಫ್ರಮ್ CPA ಅಂತ. ಅಂಟಿಲ್ ದಟ್ ಹ್ಯಾಪನ್ಸ್ ವಿ ಹ್ಯಾವ್ ಟು ಬಿ ಬಿಟ್ ಕೇರ್ಫುಲ್ ಓನ್ಲಿ.
ಸರ್ ಇಲ್ಲ ಹಾಗೆ ಮಾಡಕ್ಕಾಗಲ್ಲ ಸರ್. ಇಟ್ ಇಸ್ ದೇರ್ ರೈಟ್ ಟು ಹ್ಯಾವ್ ದ ಟ್ರೀಟ್ಮೆಂಟ್ ಅಂಡ್ ಇಟ್ ಇಸ್ ಆರ್ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ, ಮಾರಲ್ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ ಟು ಟ್ರೀಟ್ ಅ ಪೇಷಂಟ್. ನೀವು ಯಾವ ಊರು ಅಂತ ಕೇಳ್ಕೊಂಡು ನೀವು ಟ್ರೀಟ್ ಮಾಡದೇ ಇರಕ್ಕಾಗಲ್ವಲ್ಲ. ಅದೇ ರೆಫರಲ್ ಮಾಡಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜಸ್ ಎಲ್ಲ ಓಕೆ. ಬಟ್ ಈಗ ಔಟ್ ಪೇಷಂಟ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಅಲ್ಲಿ ಹೌ ಕ್ಯಾನ್ ಯು ಸೇ ಸರ್, ಇರ್ರೆಸ್ಪೆಕ್ಟಿವ್ ಆಫ್ ಕಾಸ್ಟ್, ರಿಲಿಜನ್, ಜೆಂಡರ್ ಅಂಡ್ ಇದು ವಿ ಹ್ಯಾವ್ ಟು, ಇಟ್ ಇಸ್ ಅವರ್ ಮಾರಲ್ ರೆಸ್ಪಾನ್ಸಿಬಲ್ ಟು ಟ್ರೀಟ್ ಅ ಪೇಷಂಟ್. ಎಮರ್ಜೆನ್ಸಿ ಇದ್ದಾಗಂತೂ ನಾವು ಹೆಸರು ಕೇಳಿರಲ್ಲ, ಟ್ರೀಟ್ ಮಾಡ್ಬಿಟ್ಟಿರ್ತೀವಿ ನಾವು ಅಲ್ವಾ. ಎಸ್ಪೆಷಲಿ ರೆಫರಲ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜಸ್, ರೆಫರಲ್ ಸೆಂಟರ್ಸ್. ಅದಕ್ಕೆ ಐ ವಾಸ್ ಥಿಂಕಿಂಗ್ ಪ್ರಾಕ್ಟಿಕಲ್ ಇಲ್ಲ ಸರ್ ಇದು ಬೀಯಿಂಗ್ ಡಾಕ್ಟರ್ಸ್.
ಡಾಕ್ಟರ್ ಪದ್ಮಾ, ಡಾಕ್ಟರ್ ರಾಜೇಂದ್ರ ಪ್ರಸಾದ್ ಪ್ರಾಕ್ಟಿಕಾಲಿಟಿ ಹೇಳ್ತಾ ಇದಾರೆ, ಯಾವ್ಯಾವ ತರ ನಾವುಗಳಿಗೆ ತೊಂದರೆ ಆಗ್ತಾ ಇದೆ ಅಂತ. If in case you want me to give my comments, first and foremost, most of our doctors still do not have professional indemnity. Either it has expired or they would not have taken it up at all. And now Dr. Rajendra Prasad clearly told that even ESI doctors and government doctors also need to be cautious about this. That's one message. Second thing is, whenever we refer a patient, we find that the doctor at the other end, it's not the senior doctor or the HOD, the junior residents, they pass loose comments. Mogun ishtyak late karkomandidira, mogug VSD ide, yake nim doctor helilva? VSD may be missed in scan. Yake nim doctor helilva nimge? So these comments happen because of the junior doctors. So I suggest that all our professors or HODs prime their residents and tell them that they should not speak anything about the patient when they are asked. Anything and everything the HOD does. The example that they have to give is, don't you watch TVs? In the TV, when one senior politician is being interviewed, do you think other people will pass any comments? No, they just keep quiet. Similarly, the junior doctors should not open their mouths, particularly whenever a bad case is referred to from a smaller center to the higher center. I tried to track one such incident. One patient was referred from a rural pediatric case was referred from a rural to the next higher center. These people came back and killed the doctor on in the motorcycle accident. That is because I believe they said that the baby was referred late. So my sincere request to all our colleagues is, please discuss the case between the four walls amongst each other about the case, so that we can treat the patient better, not pass loose comments in front of other cross specialties also. I don't expect a pediatrician to discuss his case with a cardiologist. Similarly, a cardiologist with a pediatrician, because you know the depth of it. We have no right to comment on our cross specialties, and definitely with the other professionals. I have a close friend who is a teacher. I cannot confide to her and tell that my colleague did this, did that, etc. And definitely the last two words what I have to say is, let us not show by expression or words in front of patients when they speak ill about another doctor. And another thing is professional indemnity. Let's all make sure that the renewal is happening properly, and let us create awareness amongst all our youngsters about professional indemnity. Thank you.
True, Dr. Anuradha, very well said.
Yeah.
I do remember that the doctor was killed when there was a loose comment by the one more doctor where he took the case. Definitely very threatening and horrifying this is really. So I think we have to be more cautious when we utter a word about our colleagues. Better to avoid. Thank you once again, Dr. Anuradha. And there is one more question from Dr. Satish. Can we take consent in pre-typed form, not handwritten?
No, pre-printed should be completely printed. Name blank, age blank, like that it is not, it should not be. Everything written or everything printed. That means it has to be very much specific to that patient. You see, how the law sees is, it is a contract between that patient and the doctor, highly specific to that particular procedure. That means it cannot be a pre-printed form where the blanks are there, you fill it, and this thing, where you can fill anything. Just take the signature in the bottom and fill everything, fill up the blanks. That is an unfair trade practice, and that should not be there. And regarding this thing, consumer court jurisdiction, earlier it was the place of treatment. Now they have made it place of residence also. We should fight against it, one. And number two is, if we have indemnity insurance, we need not worry about it. Wherever, if the patient is a Bihari, our IMA KSB has indemnity insurance, they have to take care of it. Those advocates will take care of it. But in general, I am telling that we should fight this. And if the CPA goes, everything goes off. But this amendment, what they have done, anywhere they can sue the doctor, that should change.
Hello.
Yeah,
Sir.
Dr. Satish, please
No,
go
I just
ahead.
wanted to ask, what about patient themselves? They'll record they'll make a record of a videos while we are counseling. Patients also, they'll take a picture and they'll record. That is okay?
Sir, that is what exactly the thing. Better you record and give them the copy. So that
we would have recorded. Usually the consent also, they'll take a mobile phone and they'll have that speaker on.
No. You see, that is nothing wrong, because that is what the law expects. The patient has got right to know everything. When he has got right to know everything, instead of he recording, you record and give a copy to him.
Yeah, that will do it. Usually we record everything in ICU.
That rule is there in every office. Even if you go to the police station, that is the law. But everywhere it is not followed. But we doctors have to follow it.
Yeah.
Because we are the soft targets. That is the problem.
True, sir. Better rather they record and give it to us. We record and give it to them is better, I think. And we can explain them in a better way.
Like usually we only ask them to keep a mobile on the table itself, sir. So that our voice also will get clear to the one who wants to hear. That is what we usually tell them.
Thank you, Dr. Satish.
Thank you.
Any other doubts or personal experiences?
Padma, another observation is, these patients have a tendency to record the conversation. Suppose they make a phone call to you, they'll be recording it.
True.
Madam, nan hೀಗ್ ಆಗ್ತಾ ಇದೆ, ಇಲ್ಲಪ್ಪ ಬರ್ಬೇಡ. Madam ಬರ್ಬೇಡ ಅಂತ ಹೇಳಿದ್ರು. So it is recorded. So every phone call is they record. We can some of us we can make out, but sometimes we may not make out. One. Second thing is, when they walk into your chamber, when you are speaking to the patient, she will be comfortably recording, and You have to make sure that they keep their mobiles outside when they walk into your chamber. So this recording has become very rampant. Patients are doing it in and out, irrespective of the class of society. Thank you.
And there is one more thing, madam, that even to this year's World Health Day slogan is also that my health, my right. The meaning of it is the privacy. You see, whatever patient is there, patient's record is there, that is everything is private. No third person has got any right to over it. And that is a big problem, because any case sheet, either it has to be in the hospital or with the patient, and it should not go to third person. If you are giving a discharge summary, particularly in MTP or any other things, you have to take very, very clear consent from the patient, and then only you should give it. Of course, in the post-hoc, entirely different. On the day patient, the below 18-year girl, pregnant girl walks into your clinic, you give a number and nowhere her name comes out. Only the doctor knows it. If it is leaked under it, it is leaked from the doctor only. Even the police officer also will not know the name. The only number has to be given to him.
This is another very important thing. Any MTP, we are not supposed to reveal the name of the patient even to the police. Yes, this
Yes.
also we have to note.
Sir, can I pitch in a point? I'm Dr. Sameer Singh, a group medical head for CK Birla Group of Hospitals. So, sir, we do.
Please go ahead.
Sir, we also are very strict on MTP's name not being disclosed. Lately, what has happened is that there are a lot of young girls who are just about to come to 18, they are 17 plus, and we have not disclosed the name, but we're in a dilemma between whether the POSCO comes in or the MTP Act. I believe the MTP prevails because that's a privileged information to a consultant. They have not come to know the age of the patient because they were their neighbors. They came to know because they were doctors, right? So for us, there's a dilemma, and when a couple of times what has happened is we haven't reported. The patient has gone to a neighboring neck center for an ultrasound confirmation. They have reported, and then police has come and troubled our doctors for not reporting. So a lot of times I get into a situation where my doctor says that we have been trying to mislead them and they should have suo motu reported to POSCO. A couple of cases have come up like this in the last 2 months itself. So please guide, sir, if there is somebody who's about 16, 17, I say, since we don't have to collect any identification, means I don't know the age. Unless and until it's very obvious somebody's 13, 14, and has come pregnant, is a domestic help, has come for abortion. Please guide, sir.
Yes, sir, you are right. One doctor was in jail for 14 days for not reporting a pregnant lady of below 18 years. So it is the doctor's duty, and so also it is a punishable offense not reporting to the police. Any pregnant lady come to you, not for MTP, even for a headache. If you come to know that she is pregnant and she is below 18 years, she has to be reported to the police, and that is what the law says.
Sir, your voice is breaking, I think.
Yes, sir, it's audible, sir. Go ahead, sir.
Yes, sir, am I clear? You want me to repeat? Dr. Sameer Singh, am I clear to your question?
Sir, I heard your answer, sir. But are we not then breaching the MTP Act and discouraging the patient to not come to us because we will, for the fear of reporting, and then they'll end up with a quack or trying to do things at their home, reading from internet?
No, sir. Law of the land we have to respect. Wherever she goes, that is her headache. But law of the land we have to respect, and we cannot hold her. You see, you take the identification of her, and inform the police, better by email. Because tomorrow the police should not say that we have not received any call from you. So better send it by email. And you cannot hold her. That is also an offense. And police will trace her anyway. But informing is the doctor's duty, and not informing is a criminal offense. That is criminalized under POSCO Act. And disclosing her name is also criminalized. And for that also there is a punishment. The imprisonment punishment is there.
So then how do I inform the police, sir, without disclosing her name?
Here.
No, number.
Can I speak here?
Yes, sir.
Yeah, I'm Dr. Sarvesh. See, in POCSO, you are disclosing the name to the police authority. Name, address, phone number, everything will be given to them. And also, how we know the age? It's as per the Aadhaar card or anything else. We have to take it. We should collect the document and send it to them. Because after that one, if you don't do that one, it will be an offense, as you said. And you can inform the CDPO or the government hospital nearby also can be informed. And the second thing is, we were discussing about the consent. Nowadays, what they do is audio visual consent. They record it in many of the hospitals now. Whole process will be recorded. Whether the patient or patient relatives records the conversation is not wrong there, because we are also recording their thing. And disclosing the name here in POCSO is not an offense. We have to give the detail of the patient and the husband also, if we know that one, because we'll be taking the husband's name also. Both the things should be given, and other things will be taken care by the IO, investigation officer. As you said, if we don't report, it's 100% offense, and they will take the advantage of that one. The police and others also will take the advantage of that one to harass and to collect many of the things from the doctors.
Sir, when if a patient comes to me for abortion and I know it's an MTP, am I supposed to collect her identification?
Definitely, yes, sir.
File it as well for my own records?
Sir, definitely, yes. Otherwise,
now, as per the MTP Act, after this, the PCNDT, they have visited all the institutions, how many abortions has been done, and every detail, if it is not recorded, it becomes an offense. Each and everything to be, you need not disclose those things. If it is above 18, if they have come by this by themselves, you need not inform them. But you have to take the consent and you have to record the each and every point of the history was documentation, what they said in the beginning. The documentation is very much important in this one, because they will connect it to PCPNDT if it is a female child.
Sir, good evening, sir. I'm Dr. Anita, gynecologist. Now we have this eKalyani app, sir, that we have to upload in that app also. We have to take an permission from the DC, from the DHO office.
Yes.
And then upload, and then we have to do the MTP. You cannot do the MTPs without uploading that case in that app. Now they're very strict, sir.
Madam, what about oral MTP pills being given for administered at home?
Sir, that is that we take it under medical termination. Sir, we have a one consent form given by Foxy, sir. That consent form should be filled up, and you have to give details, like suppose if you are dispensing that medical termination drugs, sir, misoprostol or mifepristone, like you have to give a detailed prescription with your seal and KMC number, sir. Then you should have a scan before you're terminating that medical termination. You have to have a scan before you terminate, and later after post-abortal, you have to one scan. like pin both the scan reports in the case sheet, sir. Like case sheet means you have to keep that medical, this one, whatever the consent form you had, that you have to do it, sir.
And the
You
details
cannot
have to be-
blindly prescribe the this abortion pills.
And we have to still enter details in the MTP register, even if it's
Yes,
not in.
sir. That eKalyani app, you have to, like, I think you have to upload it, and every month, 5th, the date of every month, we have to send it before 5th of every month. We have to send it to the DHO office. And you have to take the acknowledgement also, sir. So that is also is very important, because anytime when they come cross-checking, you have to have that acknowledgement, what you have, how many abortions you have conducted, or how many medical terminations you have done in the hospital.
Thank you.
Ma'am, how long is this, Dr. Anita, this eKalyani?
It's there from almost 7-8 months. Because I have taken the permission from 7-8 months. Just when it started, 2-3 months, I didn't take it. I was just waiting for it. Like, because they had given the permission, we have to take this MTP permission from the DHO office. No, I was thinking I had that permission, so I can do it. But again, we have this child welfare officer told no. You have to upload the every case.
And who can
And,
visualize the details? Only DHO, THO officials or even the public?
No, we will upload in the app. I don't know who can visualize. I'm not
Because
very
anybody
sure
can
about it.
download anybody can download the app, no? They can view.
No, it
Are
is
you only
given by
confidential?
it is given only after giving all the details, all the permission what is given by the DHO office.
I know, but who can see those details? Only the government
I don't know.
officials
I
or
don't.
even the public
See,
can?
it is the RCHO
RCHO, yeah.
and the
It's RCHO, correct, sir.
office workers will be there. One who uploads, they will be knowing, and
think
that cannot be disclosed.
Government
should not
officials,
be
DHO,
disclosed.
THO also, I think they can visualize.
DHO also knows, and the persons, the data entry operators, they will be knowing actually. Okay, that's what I'm
just
telling you.
like
Staff of that concerned department, it's RCHO, or the family planning officer. These are the two one who handles the things. You have to take it the permission from the RCHO. DC will be is the chief of that committee.
Yes, sir. Yes. So one more thing here is like if you're conducting an MTP after 12 weeks of gestation, you have to take another gynecologist opinion also, or like you have in that app you have to have another gynecologist. All her KMC registration, everything, all her details should be uploaded in that. After 12
as
weeks.
per the
First
law,
it was
what it says, till how many weeks you can do the MTP?
Sir, any weeks you can do, whether if it is indicated, sir.
Yeah, that is
Any
the thing.
weeks you can-
Indication is
yeah.
important.
Yes.
If it is indication is not there,
Yes.
clear-cut indication should be there. That should be mentioned, and you should have the documentation of that one. Then you can do. You need not have the another gynecologist for that one.
Failure
Sir,
of
for here it was compulsory, sir. It was compulsory that I had to give my friend's KMC registration number, and they saw that when it was registered. Suppose if our renewal is not done, that KMC certificate was not accepted here, sir.
Yes. That is for true.
Yes,
Because
madam.
the KMC registration is amended now.
Yes, sir. And if it the renewal dates are not there in that, then they are not accepting that KMC
You are not
certificate.
entitled to do that one. That's what they say.
Yes, sir.
By the KMC, you are not permitted to do that.
Yes, sir. See, now I have one antenatal case. That case is around 32 weeks, but it was cardiac anomaly was detected around 26th to 27th week. Means like then I told her, like even there also they told, and she took many opinion that that baby should be terminated, otherwise immediately on the 3rd day or 4th day of the birth, like the baby has to undergo the cardiac surgery. So it is a major surgery, and they cannot give 100% guarantee for the baby. But there she went to Bangalore and she went to all health department and all. They did not give the permission to terminate. Now she's due next week for the termination, that too in Vani Villas, and this Jaideva Cardiac Institute has agreed to operate on that baby. Even if she doesn't want that baby, they are not giving the permission until it is clearly indicated to terminate the pregnancy.
Yes, if it is, as you said, it is 32 weeks.
Now she's around 36 weeks completed,
Yeah.
sir. When it was diagnosed, it was around 27th week. They did not give the permission, sir. Here,
That's
especially
what
the
they say.
DHO
You
and
have
all,
to-
they didn't give the permission.
No, nowadays what they say is you have to take the permission from the court.
Yes,
From the
sir.
board, sir.
Yes,
From the board, there is a
board,
One
board
will
also can be taken, but usually the board will not permit you.
will not permit.
They are
yeah.
also scared actually. If
No, the
something,
thing is-
some, no, if some relative sues for that one.
No, but the
See,
problem.
many of the things you will be seeing in the paper actually, or in the news. Maybe probably it is the under 18, that one. You may be right. Yeah, it's under
No,
18. You have to take the permission from the court.
Oh,
Here, probably you can do it with the concern with the board or with the, as you said, another gynecologist and the other things can be done.
Actual problem here is risk to the mother. When such a big uterus is evacuated, that is whatever method you
That's
take,
why they don't permit.
risk is high. Nobody wants to take risk. It is unnecessary risk.
Sir, whatever it is, sir, like before and all, we used to do the MTPs. Safely, we used to do the MTPs when the DHO, when we used to take the certificates or permission, or if we have undergone the training and all. But now for even unmarrieds, they are not giving the permission, sir. Now, like last week, one unmarried lady of 23 years old, she delivered, and they told we will deliver her and put the baby into the Devara Tottalu and go. That's what. Like, see, she left the baby in the government hospital and went for the Devara Tottalu. So even the baby is suffering, Allah, sir, there. They may give for adoption, but still this permission and not allowing to abort this unwanted pregnancy is leading another social cause here.
Yes, again, in the rape case, some of the cases they permit, that is the court order. But
Yes, sir.
otherwise, when the patient child is viable, the question arises, isn't that child has got the right? That is very difficult to answer that question.
Yes, sir.
All these things started because of the female feticide.
Female feticide, yes, sir.
Okay, and the whole of the society doesn't believe or faith in the health profession. They take all the things, they get all the positive things also. They themselves, they get the things also terminated also. But when you come to the public, they say they do it for money. See, some of the issues came now recently.
Mandya issue.
Mandya issue. Mandya issue. Mandya and Mysore, what happened? After that one, they are taking stringent action. They are visiting each and every scan centers. They are harassing them also. See, we are not good with our own colleagues. They can advise. See, you are doing like this. Don't do that one. Don't do that one. We have to watch. We have to interfere in your things. They will not guide or advise or anything, because the IAS fellows, these people have to answer to them. Then they will say, you have hand in glove with them. That's why you are not reporting. Do you think none of them are doing this? We will attend. We have attended the meetings with the IAS officers. Some are good. Some they say, you people are not doing the job properly. Each and every question they ask in their own way. They extract that one. How many you have done? How many action you have taken? Notice how many you showed. Those things will be there. So two things are there. It's a double-edged sword for us. For the department, they do it in a good way also. And the other way also, to extract the money also, they do it. But to be safer on site, if we do ethical practice with clear-cut documentation, nothing wrong is going to happen as per the rule if we go.
Lalitama, she says that MTP, her name will be entered in the OPD as soon as she comes. I think from the time she enters into the OPD, they do have records, I think.
If she is above 18, there is no problem. But the thing is that that record should not go out. That is what.
Should be confidential.
Yes, should be.
Sir, the records will be confidential only, sir, as per the rule. If the wife doesn't give the consent, you're not supposed to show the case sheet or the copy of the case sheet or anything to her husband also.
Yes,
as
sir.
per law. It is the privacy part if it comes. See, many of the things become, especially in MLC, it comes actually. The other part also that can be applied. Without the consent of the person suffering, unless he is a minor or mentally retarded or anything else is there, we are not supposed to disclose the history or anything without the consent of the patient. If it can be a parent also, husband also, the kids also, as per law if we go. But we can't follow those things. To save our own skin only, we have to explain the things to the relatives in front of the patient. That becomes a consent. If they go and ask for the thing in RTI, then you can say it cannot be given. It's a personal data that cannot be given unless the patient herself or himself asks for that one.
Yes, sir.
Any other questions? Any doubts? Leela is there. Girish. Dr. Suresh Kagalkar, are you there?
Probably he must be in the OT.
Dr. Jai Prasad, sir. Shall we come to the end of the session?
Yeah, already HMT time.
Suresh sir is not there, ma'am.
Yeah, he's not there. Okay.
Can go ahead, sir.
Dr. Jai Prasad, sir, can you hear us?
Yeah.
Any doubts, any queries, or any experience, or any suggestions?
The second opinion of a gynecologist has to be taken only after 20 weeks, I think so. 20 to 24 weeks.
Sir, now they're asking after 12 weeks, sir, as I know, because 2-3 cases when I had reported, they told you have to take another opinion, madam.
And in the latest second trimester, second doctor gynec is not required.
Hello. Hello.
Here, actually, they had asked for me for the 2 cases after 12 weeks. They told you taken, depends upon the medical, this RCHO officer. Yeah.
Hello.
If he is very strict, he will ask.
That's what, it's double-edged.
Yes.
But what about textbooks, madam? What we read?
Hello, I am here, Dr. Prabha Devi.
Hello, please go ahead, ma'am.
Can I speak to you?
Definitely, go ahead, ma'am.
According to recent amendment, to a gynecologist's opinion should be between 20 to 24 weeks, not before 20. Up to 20 weeks, one person can do, authorized person can do. Whereas between 20 to 24 weeks, you have to take second opinion of a second gynecologist. After 24 weeks, it is nothing but medical board decision. Not after 12 weeks. Clearly mentioned, recent amendment.
Yeah, this is a recent amendment, Anita.
Madam, have you taken eKalyani app for your hospital, madam?
eKalyani app we have not yet taken in Andhra Pradesh.
You apply for eKalyani app, madam, then you
Then
will
I
know
will
the
go through
recent
that.
amendment. Yeah. See,
But,
without that, see, when we apply only, we'll come to know what they are asking, madam.
But as per
And
all over nation, the amendment
it's
has
there,
given
madam.
that.
Even they were telling that, up to 28 weeks you can terminate, you can terminate. But recently that cardiac anomaly child, they did not allow us to terminate at all.
Once
Even
any anomaly that is incompatible to life, that is given by radiologist, a gynecologist, and some other authorized person, three-member board person, they give opinion. Definitely, we can go for termination. But here, why it is not given, I don't know. Maybe
because,
viable,
when
maybe
it
doubtful
comes to
compatibility.
the
No, my question here is it a preventable cause or non-preventable cause? Is it a preventable cause or non-preventable cause?
Which one?
Infant death or any of the deaths,
That's why I'm
maternal
telling
death also,
incompatible to life.
Yeah.
Incompatible to life, definitely they give the opinion. But on the doubtful aspect, they may or may not give the correct opinion. In that case,
See here, the history-wise, what it was found in the scan during 26th or 27th week, which was late for family scan. And also, they said is if it is operated within how many days or week, the baby can survive. It's a question mark there also, can survive.
But
that becomes a preventable cause.
But sometimes patients, they may not have that financial aspect to bear the burden of the surgery and all. In that case, very
No, that cannot be considered here as per the law.
Sir, here in Chikbalapur, we are not able to terminate the pregnancy without eKalyani app. Sir, how so many have not taken this app at all because they are very strict visiting the hospitals, all that. But when you are applying for eKalyani app, you will know that there are so many rules and regulations which has been again introduced newly. Because when they were asking me also, I was just asking them the same thing, but they will not listen. It depends upon the RCHO officer and how many times they visit your hospital.
Yes, madam, you are right. Because one of the hospital in Nelmangla had a problem some time back, not reporting to the DHO every week.
Yes, sir.
I think you are correct that everybody.
Because today I was there with the district commissioner for 4.5 hours because of this discussion, sir. So there were Gauribidnur, Chintamani, and then Shidligatta, Bagepalli and Chikbalapur, all the medical officers had come. We had this maternal mortality. That time they were again stressing out on this MTP, sir, because of the antenatal deaths. So this one, when you apply for that app, I think the many rules will be again told, what we have to give, how we have to report it, how we have to upload it, everything they will just guide. They will send one person to train us, sir, how to upload this MTPs into that app. Yes.
That is going on in your Bangalore?
No, Chikbalapur, madam.
Okay. But even national-wide, we are getting webinars from Patel, medical legal aspect experts, but nobody has told this eKalyani app and all. And simply we are sending all F2 forms.
Madam, how you are reporting your MTPs, madam, then? How you are reporting to
we are
the...
reporting to directly by sending F2 form 2.
That is not accepted now, madam. That F forums is for scanning, madam. Like this MTP, this one first we used to report from this HMS forums. From this HMS forum, but this HMS forum also has become online now. So when we are reporting the MTPs, we have to, they have a different rules now, madam. When you start uploading that, you'll stop doing MTPs only. Like it's quite complicated one. But if you are well versed in uploading that, it is
I
easy.
can play with this.
Everything we should know. Uploading. You told Anita Garu, you told MTP before and after scanning is important for medical method of termination of pregnancy or any other method?
No, for medical termination, because first you have to show that at what weeks of pregnancy you have used the medicines, and after the abortions, after 48 hours, you have to have one scan and tell them it was a complete abortion.
But
Otherwise, if she
even this is also not being mentioned by experts of medical legal, but for the first time I'm hearing from you. The scanning
it is
may
that,
or may
madam,
not
like,
be required, they told. But medical
madam,
abortion,
suppose if she have incomplete abortion, how you will come to know, madam? After 15 days, if she comes with bleeding and incomplete and sepsis, and again you will have the complications of abortions. So it is better to have that and tell the patient that it is complete. And
even prior to giving the pills or an abortion, to know whether it is in the fallopian tube.
Yes, to rule out the ectopic pregnancy.
Ectopic pregnancy also you can rule out. So I think that is indicated.
And they have given us medical termination of pregnancy can be done within 43 days of the LMP. It must be within 43 days. So if you give the pills at 7th week or 8th week and all, again, we are again into the problem, complicating the patient. So it is important. Even I feel that it is important, madam.
Sir,
madam.
Sir, one more question
Madam,
here.
can I
In the
disturb?
hospitals here, when they do the ICU admissions or any surgeries, the consent of the patient, along with that, they have a doctor's signatures also. So does the consent form will have the signature of the treating doctor as well as the owner, the KMC number also, sir?
No, treating doctor.
Only treating doctor KMC number, name with signature, that's it. Not the owner's.
No, madam. Owner necessarily need not be doctor.
No, if the owner is a doctor,
no, it does not make any difference.
Only the treating doctor.
Treating doctor is responsible because something goes wrong. Who treated
treating
the not the owner.
Okay.
That is why we say from the IMA that these corporate hospitals are exploiting the doctors. You see, when the hospital, when the corporate hospital make a bill of 5 lakh rupees, hardly they pay 25,000, 30,000 to the treating doctor. Is it not exploitation? It is the same exploitation even in the medical colleges also. And every responsibility of medical negligence doctor takes, not the hospital owner or the medical college. It is the doctor who has to fight his case. So all the responsibility is of the doctor and all the money is for the hospital.
Once the Consumer Protection Act came and it became a trade license and all, so health sector is also become a business mind, sir, because they say they provide air condition, a star hotel kind of rooms, and one ring of a bell, a nurse or attender, they will go and attend, even the attenders, patient attenders, they will take care. They give a royal room, sir. So they feel they are in a 5-star hotel rather than in the hospitals.
Madam, that part I am not disputing. That they are not disputing.
That is the reason they do charge so much of bill.
I am disputing only that doctors are exploited everywhere, whether it is a corporate hospital or the medical colleges. Medical colleges, solution, professor having 15 years experience, they pay peanuts.
Sir, what is the solution then?
No,
not to get exploited.
No. But the main problem is there is no unity among us. That is the problem.
Sir, it is not the unity. What happens is you have to see the appointment order they give in the corporate hospitals or in any of the private hospitals. They put all the conditions. And if you're, as a clinician, if you're treating any of the patients and any untoward effect happens, it is you solely responsible for that one. Hospital cannot be held responsible because of your fault. That line they have added now from past few years. See, they safeguard themselves in all the ways because it is run by MBA people. They want money. They don't want any of the risks. And risk-taking people are there, like our profession people. They need more money. They want to work in the corporate hospitals. They get the money, and in multiplication, they get back their money also, the hospital people.
Padma, what is the solution ಅಂತ ಕೇಳಿದ್ರಲ್ಲ ನಮ್ ಡಾಕ್ಟರ್ಸ್ ಕಾರ್ಪೊರೇಟ್ ಹಾಸ್ಪಿಟಲ್ ಅಲ್ಲಿ ಸಿಗ್ನೇಚರ್ ಮಾಡುವಾಗ MOU ನ ಸ್ವಲ್ಪ ನಿಧಾನಕ್ಕೆ ಓದಿ ಕೆಲವೆಲ್ಲ ಕ್ಲಾಸಸ್ ನ ಖಂಡಿತ ಅವರು ಬದಲಾವಣೆ ಮಾಡಿಸ್ಕೋಬಹುದು. ಶುರುನಲ್ಲೇ ಬದಲಾವಣೆ ಮಾಡಿಸ್ಕೋಬಹುದು. ಅವ್ರು ಮಾಡಿಸ್ಕೊಂಡ್ರೆ ಖಂಡಿತ ಕಾರ್ಪೊರೇಟ್ ಅವರು ಈ ಡಾಕ್ಟರ್ ಕೇಳಿದ್ರು ಆ ಡಾಕ್ಟರ್ ಕೇಳಿದ್ರು ಅಂತ 10-20 ಜನ ಡಾಕ್ಟರ್ ಕೇಳಕ್ ಶುರು ಮಾಡಿದ್ರೆ ಆಟೋಮ್ಯಾಟಿಕ್ಲಿ ಥಿಂಗ್ಸ್ ವಿಲ್ ಚೇಂಜ್ ಫಾರ್ ಅಸ್. Things are not changing because these people, our doctors are blindly signing. Not blindly signing, they are saying yes to all their terms and conditions. And that's the solution. And some of our doctors are very smart. They don't get into the corporate. And if in case some clause is there, they will get away from that, or they will make a separate MOU for themselves.
Even
That's
in
my observation.
Even in Procto, the same thing. They charge the patient 2,000 rupees and give the doctor 600 rupees. And all the risk is of the doctor. And what they give is only the link to talk to the patient. And is it not exploitation of the doctor? All the risk you take, all the money they take just for giving the
But why should we seek that?
One thing, let us discuss why it's happening.
Because you yield to that. You agree for that. Proctor people approached me, I refused. They approached Dr. Rajendra Prasad, he refused. But others haven't refused.
See, 10% or 15% will refuse. Or let it be 30% will refuse. 70% is there for them. They don't want any 30% people. 70% people are ready for that one also.
Yes.
In competition. We are in the competitive line now among ourselves.
Amongst ourselves. Okay, Padma. And Dr. Lalitama has put a comment. I do agree with her. Scanning after 48 hours does not help at all for medical abortion. We normally do it after 14 days. What Dr. Anita said, I think we need to cross-check and find out. And Dr. Rajendra Prasad, amongst the medical officers also, there's a lot of dilemmas with respect to the rules and regulations they have made. So they are also finding it difficult amongst themselves.
No, madam, there is a high-handedness. That is what I observed, that they think they know everything, and these IAS officers, okay, there is so many scanning centers, why we need so many scanning centers, close some of them, find one or the other reason and close, and all. There is a lot of exploitation also. Another question is, one IAS officer wants to know why so much of increased rate of cesarean section in some of the hospitals. We go and find out these things. You see, the patient has got right, whether the patient has got right to choose the treatment. Nobody should be asking this question, why the MTP rate is high or cesarean rate is high. These are all, but they are in the authorities and they can question. That is what.
So the bill will come now, sir, after LSCS or any surgeries. So they do give the bill. So they write consumables, nurses charges,
It is not question of a bill, madam.
And that is the end of the
Out of 100, how many?
High, it will be expensive.
No.
For cesarean, if they're charging 1 lakh rupees, the consultant might get 18 to 20,000 rupees. Remaining 80,000 rupees will be room rent, nurses charges, OT technician, consumables.
No, madam, my question was entirely different. My question is, of
The
the
IAS
rate
officers
of
are asking
100,
why the charges
how
are
many
very
are normal delivery, how many are cesarean section? Why so many cesarean section is high?
Not the cost wise. Okay.
They should not be worrying about it. Either they should improve their facility and do it, or they should not be questioning any of the hospital why your cesarean section rate is high. Because the patient comes to the private hospital because they would have gone to the government hospital and they maybe some complication would have happened. Then that is why they would have come.
There are so many medical indications, no, sir, for LSCS.
Indications.
Yeah, that's what.
On the
What
top of
will
it,
they know?
No, the
Indications of
IAS
medical
fellows, as
cesarean.
you said, they go for the literature. Literature is there, 10 to 15% of the deliveries can be cesarean. That's what they consider. They will not go for the depth of the things because they don't have the knowledge. If they know also, they will not accept that one. See, the data is there. As per the data, it should be less than this one. Why you are going more than that one? Then they will do the survey. Some of them, they will say, they said this indication, but they did it. Some of the indications are not documented. You cannot document the things at the time of delivery. If it is delivered, documented properly, if you give the reason for that one, they will accept it also.
No, now the thing is patient
some of
also
our
has got the right to
gynecologists
choose the
only,
treatment.
this here, some of in the meeting, some of our gynecologists will say, these could have been allowed for normal delivery. They say there also the argument comes there also. If something happens, they will be handling with 2 lives. If something happens to one also, there also we are questioned. If we do this one also, we are questioned. So where we are standing now is here.
Yes, sir.
Yeah, shall we conclude?
Anuradha, yes, sir. Anuradha, you told no, the scanning is done after 48 hours and they have not mentioned within how many days. Even if it is done at 14th day also, suppose if she is bleeding after 1 week, then what you will do? You will subject her to scan, no? To see any return products of conception. So they have told not before 48 weeks, 48 hours. Yeah, it is after 48 hours they have told. They have not mentioned like how long. Even they can be a scan can be done after 1 month also. No problem. But if after 5-6 days, if the patient comes back to you with the bleeding, then what you do? You tell I'll do scan after 14 days. No, you will do it immediately to see any return products of conception.
Yes.
So that was the intention of they telling after 48 hours, not before 48 hours.
No, Anita,
See, because some
practically,
patient will, yeah.
let us be practical. But at the end of 48 hours, the products would not have been expelled. Most often, they take more time to expel the products, and the abortion will not be complete in 48 hours. So,
it is not the question of, you want to see whether your, whatever the tablets, what you have given for the termination has acted or not. Because
That's
after 14 days, her weeks will get increased and patient may not agree with your, and again, she'll be around again added 2 weeks with that. Then it is difficult to subject her for this one, abortion.
The protocol is it should be less than 7 weeks, and now up to 9 weeks we can give the tablet, and after giving the tablet we watch the patient. If in case we clinically you find that that it is incomplete and she's bleeding more, we subject her to termination after doing a check scan. For all practical purposes, all of them end up with complete abortion. And at the end of 2 weeks or for 14 days, as a protocol, we do a check scan to make sure that the abortion is complete. That is
what they tell is to scan after 48 hours, not before that. That's all. But they have not mentioned like you do after 14 days or after 1 month like that.
Both are right actually.
48 hours, Anita, nangellu ivatte nan kelskondiddu. So far I haven't heard it anywhere.
Because that's why, within 48 hours only. See, now you terminate, you give the empty pills for tomorrow, and if you tell you come off after 1 week, it will get aborted, nobody will agree, and it will not act also practically. See, it will act only within 48 hours. See, once you give her the mifepristone and after that you give her the misoprostol, or you insert the tablet and send, she'll start bleeding after 4 hours or 5 hours. She will not start bleeding after 5 or 6 days. Practically, when you see the case, even if it is an early pregnancy, and you ask this one representative, if you ask, when they are telling, they will tell, madam, try to prescribe it within 35 to 38 or 40 days, madam. After that, it is little doubtful only. Because they would have seen the census, no?
Correct.
That's what, like, now normally I don't prescribe much of MTP pills, but
They take it at the counter, no? So they don't come to us at all.
yeah.
They buy it at the pharmacy only. Dr. Prasad, Padma, ಟ್ಯಾಬ್ಲೆಟ್ ನುಂಗೋಕ್ ನಮ್ಮ ಹತ್ರವರೆಗೂ ಬರೋದೇ ಇಲ್ಲ ಅವರು. ಸ್ಕ್ಯಾನು ಮಾಡಿಸ್ಕೊಳಲ್ಲ, ಡೈರೆಕ್ಟ್ ಆಗಿ ಮೆಡಿಕಲ್ ಸ್ಟೋರ್ಸ್ ಅಲ್ಲಿ ಟ್ಯಾಬ್ಲೆಟ್ ತಗೊಂಡ್ ಬರ್ತಾರೆ. ಆಮೇಲೆ ನಮ್ಮ ಹಣೆ ಬರ ಚೆನ್ನಾಗಿಲ್ದೆ ಹೋದ್ರೆ, ಪೇಷಂಟ್ ಹಣೆ ಬರ ಚೆನ್ನಾಗಿಲ್ದೆ ಹೋದ್ರೆ ಎಕ್ಟೋಪಿಕ್ ಆಗಿರುತ್ತೆ ಅಥವಾ ಇನ್ಕಂಪ್ಲೀಟ್ ಆಗುತ್ತೆ. ಆಮೇಲೆ ನಮ್ಮ ಹತ್ರ ಬಂದು ನಾವು ಅದನ್ನ ಸರಿ ಮಾಡ್ತಾ ಇದ್ದೀವಿ ಇವಾಗ.
ಅಲ್ಲ, ಏನಾಗುತ್ತೆ ಅನುರಾಧ, ಈ ಸ್ಮಾಲ್ ಪ್ಲೇಸಸ್ ಲೈಕ್ ಅವರ್ ಪ್ಲೇಸ್ ಅಂಡ್ ಆಲ್, they'll come back to us only. ಅಲ್ಲಿ ಎಲ್ಲಾದ್ರೂ ಬೇರೆ ಕಡೆ ಮಾತ್ರೆ ತಗೊಂಡಿದ್ರೆ, ಇಲ್ಲ ಮೆಡಿಕಲ್ ಸ್ಟೋರ್ ಅಲ್ಲಿ ಮಾತ್ರೆಗಳು ತಗೊಂಡಿದ್ರೆ, ಮೇಡಮ್ ಹಿಂಗ್ ಮಾತ್ರೆ ತಗೊಂಡಿದೀವಿ, ಮೊನ್ನೆ 1 ವಾರ ಆಯ್ತು, ಇನ್ನು ಬ್ಲೀಡಿಂಗ್ ಹೋಗ್ತಾನೆ ಇದೆ ಅಂದಾಗ ಸ್ಕ್ಯಾನ್ ಮಾಡಿದಾಗ ರಿಟರ್ನ್ ಪ್ರಾಡಕ್ಟ್ಸ್ ಇರುತ್ತೆ. ಸೊ ಮೋಸ್ಟ್ ಆಫ್ ದ ಟೈಮ್ ಎಷ್ಟ್ ದಿನಕ್ಕೆ ತಗೊಂಡಿದ್ಯಮ್ಮ, ಎಷ್ಟ್ ತಿಂಗ್ಳಾಗಿತ್ತು ಅಂತ ತಗೊಂಡಾಗ, ನೀವು ಅವಾಗ ಅವ್ರು ನಂಗೆ 2 ತಿಂಗ್ಳಾಗಿತ್ತು, 2.5 ತಿಂಗ್ಳಾಗಿತ್ತು ಅನ್ನೋದು ಹೋಗೇ ಇರಲ್ಲ ಅದು.
ಹೌದು. Correct. That's what we treat that, because over the counter the tablets are available now. Pharmacists have become experts in giving tablets.
550 rupees of that tablet.
I don't know how much they charge. No, I don't think it's 50. MRP is 550. They take MRP charge only.
I think very interesting topic. Shall we come to the end of the
Yes.
Already 10:30. Very nice discussion. And vote of thanks by Dr. Rajendra Prasad. Dr. Anuradha madam, please vote of thanks ನೀವೇ ಮಾಡ್ಬಿಡಿ.
Only one question and last.
Yes, madam.
Please.
So can we give prescription if anybody asks on phone or on WhatsApp?
No, I think.
No, madam. No.
Even
According to me, no, madam.
They ask like headache, madam. A patient getting treatment of our OP patient. Sometimes they may ask like, I'm getting little cold and cough, fever. Can we prescribe?
Madam, that was allowed only during the COVID times.
That's why I'm asking. It is totally no at present. No, unless it is listed on telemedicine.
No, madam, because today one ANC death was discussed because she was taking tablets for cough and cold, and she died of viral pneumonia.
Yes.
So the DC has asked her to explain the drugs and give in details written.
Okay.
So, and the patient attenders also was called, and it told, madam hatra phone ಅಲ್ಲಿ ಕೇಳ್ಕೊಂಡು ನಾವು ಮಾತ್ರೆಗಳು ತಗೋತಿದ್ವಿ, ಆಮೇಲೆ ಕಫ ಜಾಸ್ತಿ ಆಯ್ತು, ಆಮೇಲೆ ಎದ್ದಿದೆ ವಿಕ್ಟೋರಿಯಾಗ ಹೋಗಿ ಅಂದ್ರು, ಅಲ್ಲಿ ವಿಕ್ಟೋರಿಯಾದಲ್ಲಿ ತಗೊಳ್ಳಿಲ್ಲ, ಅಲ್ಲಿ ಹೋದ್ಮೇಲೆ ತೀರ್ಕೊಂಡ್ಲು ಅಂತ they told.
So
who is responsible there, madam?
Yes,
no,
madam. We are not supposed
to give anything, and if you and don't talk about the drugs in the phone only, madam, because they will record. And their thing also will go, that recording also they will bring and show to the.
Yes, true.
Auto recording ಇದೆ ಈಗ.
Okay, irrespective of anything, we are supposed to ask them to come and get the treatment.
Yes, madam, and give your prescription with your seal and signature.
So yeah, even we are not supposed to prescribe on WhatsApp also, no?
Yes,
Same
madam.
thing.
Yes.
Prabha Devi madam, from which place you are from?
So even we are not supposed to prescribe any medication on WhatsApp, on phone, nothing we are not.
Yes, madam.
Prabha Devi ma'am, which place you are from, ma'am? Where are you practicing?
I'm in Vijayawada, OBGY practitioner.
Okay.
Madam, Andhra has not having much of PCP and DT, madam, because I stay here in the border, and most of the scans are done in Indupur. And termination is done in Indupur.
Indupur is border, Anantapur and
Yes.
But we are in the central Vijayawada.
Do not
But we
speak
follow
because
all
if
the
there
rules.
are any
We follow all
officers,
the
they will
rules.
ask the details.
Yeah, we must be very careful.
But sir, officially they are doing, sir. They have not.
Okay, Padma, shall we conclude?
Okay, please do vote of thanks, ma'am.
Yes. Sincere thanks to each and every doctor, everyone who has logged in and made this webinar very interactive, interesting, and quite a lot of our queries and doubts have been cleared. And certainly a big thank you to our speaker, Dr. Rajendra Prasad. He has very well covered up Dr. Kumbar, and his presentation was too good. His slides were also too good, very, very informative. And certainly he is exposed, very well experienced with respect to the problems that doctors are facing. And that's the reason why he's picked up such good topics. And today also he's been instrumental in making this webinar very successful. And of course, the chairperson, Dr. Padma Prakash, as well as our president and secretary, and all our senior IMA doctors, and our joint secretary, Dr. Anita, Dr. Jai Prasad, President Nelmangla branch, and Dr. Rajendra Prasad is also secretary from Nelmangla branch, and senior doctors have logged in. Dr. Sarve Raj Hars gave his very good expert comments, and Padma, anybody whom I have left out? Of course, Dr. Prabhadevi madam.
Dr. Veena was there.
Dr. Veena.
Satyavati, Jai Prasad, Bhagyalakshmi, they're still online. Ravindra, Prabhadevi, Dr. Prabhadevi.
Dr. Prabhadevi, yeah. Sincere thanks to each one of our doctors who had logged in and made this session very successful. Back again, thanks to Dr. Padma and Dr. Rajendra Prasad for successfully conducting this wonderful session. And certainly a big request, 9 p.m. is too late for all of us. Thank you.
Thank you, everyone.
Thank you.
Good
Thank
night.
you.
Bye. Thank you, sir.
Thank you. Good night.
Bye.